My name is Rebecca Cantey, one of the subject matter experts from Ghana. Greetings. So we are here to discuss about the integration of FGS into existing health service delivery. This we know will be quite challenging because it might not be feasible to each and every country. So it's going to be country specific. But what we are coming to present, or what I am coming to present, is just a guide. And I know that because we are all in Africa or wherever, if you apply them, it's either you are modifying them to suit your setting, but most will work for each and every country within Africa, and for that matter, the whole continent, Ghana, Sub-Saharan Africa, and the whole continent, and wherever. So we are coming to see, or we are coming to discuss the first package for FGS, the existing structures that we think, if FGS is integrated into, will go a long way to, one, save costs, and then it is going to be time saving, and get rid of all the duplication of events that are in the system. And I think it's going to help it will bring about quality of healthcare delivery. So these are the learning objectives, that by the end of the training, learners will be able to, one, recognize why FGS should be integrated into HPV or human papillomavirus stroke cervical cancer screening, as well as they should also be able to explain how FGS can be integrated into HPV cervical cancer screening. Three, they should be able to demonstrate opportunities for integration of female genital schistosomiasis care at age-appropriate service delivery points. And then they should also be able to describe the entry points for FGS integration, prevention, treatment, and reduction of stigma and discrimination. Then lastly, they should be able to explain the considerations in terms of service delivery in low-resource healthcare settings. Now, let's look at integration in the context of neglected tropical diseases. And this, the NTD roadmap 2021 to 2030 calls for and then defines integration as grouping of packaging or several diseases, grouping or packaging of several diseases depending on their burden in countries to facilitate joint delivery of interventions through a common platform, such as preventive chemotherapy, and use of multiplex diagnostics and integrated monitoring, evaluation, and reporting for all relevant endemic NTD. So what the roadmap is saying, that integration is just grouping so many diseases with common screening or whatever management strategies, so that it wouldn't be like you are duplicating events which could have been taken care of. As I mentioned earlier, that could have saved time, energy, and then cost. It also calls for integration among NTDs, mainstreaming into national health systems, coordinating with relevant programs for other diseases such as HIV, child and maternal health, etc., and strengthening delivery of interventions through country health systems. So as we all know, there are so many disease conditions affecting women and children that we are thinking, or NTD roadmap is thinking, or calling for its integration, FGS integration into these systems that will save us the time and the hassle. Then the question is, why FGS integration? We have 4 main disease conditions that affect women, of which their consequences or the complications sometimes are irreversible. And to mention them, we have human papillomavirus infections. We have cervical cancer, and then associated with HPV, and then we have female genital schistosomiasis, and we have human HIV infections. So there are growing evidence of that addressing one has an impact or an effect on the other. And as we go further with the discussions, you'll get to understand what I mean by growing evidence has, addressing one has an effect on the other. Then we also have to look at interventions for FGS. NTDs are mostly vertical and siloed. As I mentioned, we have all these disease conditions being handled vertically in silos. But we are thinking that integration will bring about doing more with lesser time. It will be cost effective. And it's going to go a long way to save our mothers and children the hassle in moving around looking for help. So as I mentioned earlier, human papillomavirus infections, cervical cancer associated with human papillomavirus, female genital schistosomiasis, as well as HIV. We are thinking that we're proposing that the facts package is proposing that if these 4 disease conditions should be integrated, just one opportunity, you will be able to help the woman in diverse ways. Then proving why the integration. So overlapping geographical distributions of schistosomiasis infection, HIV prevalence, reported cases of FGS, as well as infertility in Africa. And as you can see the screen, I want to highlight for you to see the more. We have 4 areas or for the map showing Africa, the distribution or prevalence rates of disease conditions, as well as infertility or subfertility in Africa. So A, the cursor can show us the prevalence of schistosoma hematobium infection in school-age children in sub-Saharan Africa from 2000 onwards. And that is by Lai et al., 2015. So, can you help me with this? Sorry. So I want to, yes, just highlight it for you to see. So countries such as Malawi, Mozambique, Zimbabwe, Zambia rather, Kenya, Ethiopia, then sub-Saharan Africa, we have Niger, Chad, Sudan, then moving to West Africa. I mean, quite a lot of countries with the prevalence. You can read the prevalence rate indicated here. So those in deep green have the prevalence rate of less than 0.1. Then light green, between 0.1 to 5.0. Light yellow, 5.1 to 10 prevalence rate, I mean, in percentages, and so on and so forth. So those in bright red or hot red are those that has, they have prevalence rates more than 50%, which is quite alarming. A country like Malawi, and we have some spots in almost all the countries in Africa. So it looks like HIV, the work that was carried out by Lai et al., almost HIV is, endemic everywhere in Africa, and we need to rise up. Then looking at okay, so looking at Okay, so looking at B, HIV prevalence in Africa, adults 15 to 49 years. Same HIV. The first one is rather schistosoma hematobium, the A, schistosoma hematobium infection, and then which leads to FGS. And then the second one being the B is rather HIV prevalence in Africa among adults 15 to 49 years. And as you can see, the high prevalence rate of 1.5%, that is the darker, whether to call it a velvet or, yes, is around the southern part of Africa. Then 0.5 to 1.5% around DR Congo and some other countries in Africa. But when it comes to let's say Madagascar, yes, they are Madagascar, Niger, and some of the West, I think Mali, yes. Yes, they are recording a prevalence rate of 0.2 to 0.5. And those that are above 0.2, as we can see, I think countries like, is it Mauritania? Oh no, Algeria, and then Egypt. They are recording an HIV prevalence rate of 0.2 and no, less than 0.2, rather, it's less than 0.2. So those in the velvet, the darker areas, that's the countries that are darker, I mean, whether violet, yes, it's violet, very dark, they are recording an HIV prevalence rate of 1.5 and above. And I think it's quite alarming. West Africa to Central Africa, Eastern Africa, and all the way to the southern part of Africa, HIV prevalence rate is quite high. Then we come into image 3, being the C. So the C, let me highlight so that you see it better. So the C is African countries with published reports of FGS. And that work was done by Christianet et al. 2016. FG cases have been published by countries shaded in red. So looking at all these countries, including my motherland, Ghana, we have reported cases of FGS. And I think the number is increasing. And we don't have to sit, Africans don't have to sit, the whole world don't have to sit down aloof and get our whole continent covered with FGS. Hence, some of these sensitization and trainings for us to wake up from our slumber, start screening to be able to identify the cases, get them treated, and then we'll be targeting our efforts towards elimination. Then, yes, so yes, image number 4 or the D, a secondary infertility reported in sub-Saharan Africa. And that is from Lasan 2000. So as we can see, the scale beside the map, we can see that infertility rates 5 to 9%. There are quite a few, the clearer areas, the clearer countries, Egypt, Algeria, Libya, they are quite safe. Chad, they are quite safe. Infertility isn't too much a challenge. But if you look at the countries that are 15, they recorded more than 50, I think 15 to 19% and above. There's some similarity here. Let's compare the image C and then D. I think they have some few things in common. So countries that recorded FGS cases and then the infertility prevalence rates too, then you can see that yes, truly FGS has an impact or has something to do with female genital schistosomiasis. So looking at these evidences before us, we wouldn't sit down and keep on running the programs in silos. Hence, the call for all these conditions to be integrated so that whilst you attempted or whilst you attempt taking or make any attempt aiming at one, you are aiming at the four at the same time. Okay. So inaction on integration poses continued risk. As we can see, there had been so much work on HIV, so much work on other disease conditions, but it looks like not too much noise is being made about NTDs. This document on the screen, Global AIDS Strategy 2021 to 2023, and the focus is to end inequalities and AIDS. If this same noise is being done or is being made about NTDs, I think we'll have a long way, or it's going to have a long way to help stop NTDs and their consequences among countries like my own beloved country, Ghana, and all those who are afflicted by these disease conditions. So inaction on integrations poses a continued risk. This is the noise that we are all making today. So let's look at the work that had been done. There's some multiple calls for integration of schistosomiasis and FGS prevention with HIV prevention efforts. And I think this work was done by Noblick et al., Noblick J et al., 2011, Hotels PJ et al., 2013, Christinet V et al., 2016. And I think all the findings were a unified NTD community around the issue is the recommendation. We all need to put the efforts together, not only HIV, not only schisto, not only cervical cancer, not only HPV infections, but putting the four in one basket, using one stone to kill all this together at the same time is going to go a long way to help us. So they said there should be more awareness among the recommendations. There should be more awareness among human rights and then sexual and reproductive health rights activists. And there should also be efforts to integrate or link schisto FGS prevention activities with HIV/AIDS prevention. Efforts in Africa required accelerated programmatic action. And the action starts from today. It starts from you and I. Nobody will fight this for us. We as Africans, wherever the support will be coming from, we have to start first and say no. The same way we said no to stop HIV and we are making headway, the same way we should start crying to say stop NTDs today. The reason why we are calling for integration of FGS services into other existing healthcare services, especially concerning mothers or women and children. UNAIDS recognized or recognition that declines in new HIV/AIDS infection remain too slow. Yes, though there have been efforts, but there's a recognition that the decline is now, is just too low or very slow, and especially among young women in 25 countries, of which 18 is from sub-Saharan Africa. This is, I think, quite alarming. If to only 25 countries, the slow or the decline in HIV/AIDS has been identified as being too slow, and 18 out of these 25 countries are from Sub-Saharan Africa, then Africans, we need to sit up, we need to rise up and say no. or to make all the effort, to make all the noise, adapt all the strategies to be able to curb these disease conditions from our continent. So UNAIDS launched its prevention in 2020, the roadmap calling for innovation or innovative combination prevention packages. And it calls for the multiple needs of adolescent girls and young women to be addressed by scaling up combination program packages, thereby increasing access to sexual and reproductive health services, including that of schistosoma hematobium infection that would definitely consequently end up bringing or ending up with FGS. Now, as stated in the program outline or presentation outline, we are calling for integration. Why the integration? Why FGS? Why is FGS a community and public health issue? This is a great and a multi-billion question. Why is it a public health issue? And we have the references from key global documents, such as the UNAIDS No More Neglect 2029, and then female genital schistosomiasis and HIV, WHO 2021 to 2030 NTD map, and then introduce relevant national policies and documents, which might be country specific. So the documents, images of the documents are right in front of you. No neglect, no more neglect, female genital schistosomiasis and HIV. So we are calling for integration of FGS in the existing structures. The same way we are calling for HIV to come to an end, we are also calling for female genital schistosomiasis to come to an end. And how do we achieve that? We can only achieve that if we integrate the services of FGS into all existing healthcare services so that we can increase the access. There will be knowledge, much more knowledge among health workers and the community members as well. And all that is needed, logistics, including drugs, will be available for this fight, and we will be able to make a headway. Let's look at this conceptual framework. So the conceptual framework for the integrated programmatic implementation of female genital schistosomiasis, HIV, and HPV, cervical cancer. So let's look at a bigger picture. We're talking about cervical cancer. We are talking about female genital schistosomiasis, and then we are talking about HIV. So let's look at the strategies of each of them. So with HPV screening, HPV infection, we can single-handedly vaccinate our community members, age-specific, those who are eligible with the HPV vaccine, which is available. And then we can also screen for cervical cancer. We can also integrate people. I mean, we can also do other things. So specifically for cervical cancer, there should be HPV screening single-handedly for cervical cancer. I mean, the single one-touch events for HPV infections, which can lead to cervical cancer. And then with female genital schistosomiasis, we are looking at life course preventive praziquantel treatment. That's through the mass drug administration. Basically, we have it in schools, but is that enough? We'll look at it. Then provision of safe water. And when we are able to get to know, I know that a few discussions or much discussion or deliberations had gone on concerning FGS, the causes, and then the environmental factors that promote the spread of FGS. So if all these things are provided, if all these things are taken care of or had been taken care of, then we are likely to make a headway. Then when it comes to HIV, voluntary HIV testing and counseling, or counseling and testing, and then HIV pre-exposure prophylaxis, these are individual standalone strategies that can be done when it comes to cervical cancer and then HIV and then FGS. But existing structures that are there or strategies that are already in place, looking at screening for cervical cancer, female genital schistosomiasis, and other genital disease conditions. So what we are saying is that instead of screening for HIV alone, whilst you are attempting to screen, then you should also have in mind, HPV, sorry. So HPV screening as well as cervical cancer screening can be done at the same time. Just one screening, and you are looking out for not only HPV, you are picking a sample to screen for HPV, as well as looking for the pathological lesions around the cervix that will draw your attention to FGS. So in the clinic setting, the woman attends, and then it's an opportunity for you, whilst you are screening for HPV, you are also looking out for lesions, for pathological lesions for FGS. At the same time, when it comes to HIV, FGS, test and treat. You know, this existing structure is there where you walk into the facility and it is expected that screening test is done or screening services are given. And then when you test positive, treatment is initiated. What we are advocating for is that the same way the test and treat strategy for HIV is working, we should incorporate or we should add FGS test and treat as well. And how do we do this? So in this, a woman runs age-specific, gets to the health facility, and then there's this opportunity for her to screen for HIV. The same equal opportunity should be given to that woman, same time that she's been tested or screening for FGS. And if positive, then the drug will be available for the treatment to be done as DOTS, directly observed therapy. So the woman walks into the facility, and before she's leaving, 2-3 things are done at the same time. And then it's an opportunity. If you just carry out the HIV screening and reschedule this woman, go back and come back on a different date, there's the likelihood that you are not going to get this woman again. So we are not going to lose, or we are not going to miss these opportunities. They walk into the clinic setting, and having 2-3 things in mind, we should be able to offer the services, and it's going to help all of us. When it comes to preventive services, when we are trying to prevent HPV infections, and then we are saying that we can offer preventive services or prevention services for HPV as well as HIV at the same time. So whilst you are talking about AIDS prevention, you are educating the women, the community members about prevention. You should be talking about not only HIV, cervical cancer, but FGS as well. But the three put together, that is where the three circles intersect. So the intersection that affects the three disease conditions here, we are saying that it should be integrated. The services should be integrated. There should be people-centered care. Treatment and referral should be done at the same time, and health workforce training. So one gap that has been identified has to do with knowledge gap among health workers. So if that is the case, then capacity should be built so that all health workers, right from the training institutions, will be introduced. As they are introduced to HPV infections, they should be introduced to HIV infection as well as FGS infection as well. So that when they are coming out, the moment they qualify, they know that as part of other mandates, HPV screening, awareness creation is also part of it, so that at any given opportunity, they are talking about FGS and they are screening for FGS and treating as well. We are also saying that gender and youth-friendly services should be available. And then this one will be hammering on staff attitude. We know specifically as Africans, we find it difficult talking about our genital area. So if the attitude of the staff is not friendly enough, the woman may be having a problem, but will find it difficult disclosing it to the healthcare givers. So gender and youth-friendly services, as well as community engagement. And this community engagement will be more of the public health officers. There should be more sensitization in the communities at any given opportunity, at the deathbeds, even funerals, any given opportunity. You talk with focus groups, if that will be possible, whatever will be specifically will work for you. So you know your catchment area better, and you look at opportunities, whether the churches, the mosque, the market area, during marriage functions or funerals or whatever. So you will have to study your community and look at the strategies that will work for you. If it is community information systems, that is what works for you. The radio, you engage your people the more and make so much noise, not only about cervical cancer, not only about HIV, but you talk about FGS as well. Then one very important thing that we have to be looking at has to do with anti-stigma strategies. So all the conditions that comes with stigmatization, it should start from the healthcare givers. We should be able to counsel the patients as well as the caregivers to do away with stigma. And with all this together in one box or one opportunity, we should be able to go a long way to address not only cervical cancer, not only HIV, but FGS as well. So the entry points. We are looking at the entry point for integration, prevention, treatment, reduction of stigma, and discrimination. So there is this rich book, a document here, and it is titled No More Neglect. So No More Neglect is going to look at female genital schistosomiasis and HIV. So this document focuses on two approaches: the life course, routine clinical care, or contact with health facilities for prevention and well-being health services. It's also looking at public health programs, community-based interventions. So as I mentioned earlier, these are just guides, or it's just a guide. So you or public health officers will have to study and diagnose their communities and look for strategies that work best for them. Then they would leverage on those opportunities. But what we are saying is that having the knowledge of FGS at the back of your mind, you should, as you are talking about HIV, you are talking about cervical cancer, you should be making so much noise about FGS as well as making the services available. Now, opportunities for FGS medical interventions along life course, screening, and treatment. So we want to be age specific. Talking about the medical, initially it was the public health aspect where we have to create awareness. But here we are talking about the medical interventions, and we want to break it into a smaller unit so that we understand it the more. So we are looking at infant and young children less than 5 years. The maternal and child health clinics, we can be talking about FGS. During the immunization sessions, we should be talking about FGS. Preventive care through UNICEF's Integrated Management of Childhood Illnesses, IMCI clinics, we should be talking about FGS. So the focus is not only on the mother, but it's on the children as well, because we want to tackle it holistically. So at any given opportunity, when we are talking about services for children, definitely mother is carrying her baby to the maternal and child health for immunization, preventive care, and then also the IMCI clinics. We are saying that these are opportunities available for us to leverage on. And then we'll talk about FGS, not only cervical cancer, and I keep hammering on that. The focus is now making so much noise and adapting all the strategies to ensure that the service is available, not only the knowledge, but logistics for screening and then the treatment. Then we are looking at the primary school. What opportunities do we have available that we can leverage on? So school health programs. These days, we have our nurses moving into the school health, to the schools for school health program, and it's only immunization. Public health nurses should ensure that nurses are sensitized, nurses are trained, nurses have the requisite knowledge and skills, so that during the school health programs, they are able to impact knowledge. At that stage, nothing more, not much can be done, because you are not screening the school-going child, the primary school child, but giving the knowledge, using the languages that they can understand. Though some adults may be there, the school teachers, the teachers, and then the non-teaching staff, as well as catering services, those who handle the school feeding programs and so on and so forth. They are there that will listen to you. But I think the message should be so simple. Let the primary school child or school-going child understand or get to know that there is a disease condition called FGS, or female genital schistosomiasis. Just as you call a class 2 child and you ask of HIV, and he will be able to tell you, yes, maybe not much, but she had ever heard of HIV. We're saying same. We should be doing same for FGS as well. See, it's an opportunity that we can leverage on to talk so much about FGS. Then adolescent, 12 to 19 years. These are quite old, not too old. This is the time. We need to talk so much during secondary school health programs and other programs targeting non-school going children, especially the migrants and then the vulnerable population. Yes, he or she may find himself between the ages of 12 and 19, but due to one reason or the other, might not be in school. Let us all devise strategies to reach out to these groups. And this is the time that we need to do more for them to understand and know the consequences. They may not understand you too, but I think a 19-year-old girl, 15-year-old girl is old enough to understand you. So let us go all out, make so much noise. And those that, if it is mass drug administration in schools, let's make sure that they understand the reason why they are taking the drugs. And then there should be enough praziquantel that after the school treatment, we should be able to move into the community to also treat the vulnerables in the community as well. Then women 20 years or more. The existing strategies, we have HIV and screening and prevention. We have family planning services. We have sexual and reproductive health clinics, prenatal care, maternal and child health programs, other programs targeting women of childbearing age. We also have cervical, I think that is cervical cancer screening or cervical cancer. It is even run on outreach basis. So what we are saying is that all these opportunities are, these clinics are great opportunities for us to leverage on. And this is where action must even take place. They are old enough. If they were targeted from the primary school, by adolescent stage, they are getting an understanding what it means when you talk about FGS. And then even if they are not getting the proper understanding, by 20 years or more, when they start getting pregnant, they start, they become sexually active and so on and so forth. If we are able to impact so much knowledge, then we shouldn't be having problem with our mass drug administration. And it should not be. Now they may not be in school, but they are in the community. So this is that is where we need to lobby for enough praziquantel so that the treatment wouldn't be in schools alone, but also in the community as well. Now, so further breaking down the integration that we saw in the conceptual framework up there, we are breaking it down for us to understand it better. So what we are saying is that infants and young growing children, what are the existing structures? We have the anti-prenatal and postnatal care, not for the infants, but rather for their parents. When they are giving birth to between 0 to 5 years, they are sent to the maternal and child health clinics. They are also sent for immunizations. So definitely there will be immunization clinics within the communities, if not the health facilities. There are also preventive care through integrated management of childhood illnesses, IMCI. So what we are saying is that integrating treatment with praziquantel to these mothers at that opportunity should be able to go a long way to enhance the fight against female genital schistosomiasis. So just as for schisto and FGS interventions, we are saying that with voluntary HIV testing and services, we should test and treat for urinary schisto as well. Somebody walks in voluntarily to be screened for HIV. Why can't we take the opportunity and treat the person using praziquantel? This food for thought. So we should treatment. We are also advocating for treatment with praziquantel of positive mothers and children. So for now, we know that yes, from 3 years, there is the opportunity. In my country, Ghana, from 3 years, it is measured or it is given, praziquantel is given by height. So from KG2, when the child is like 3, 4 years, and the height is more than how many kilos? I think I wish I have the, okay, I'll show the height measure. And the praziquantel can be administered safely. Then HIV intervention, test and treat for urinary schistosomiasis using the dipstick analysis. And voluntary HIV testing for mothers and children. So these are all interventions that are existing. I mean, existing ones that we can leverage on. To be able to pass on the information and even go further to screen and treat our mothers specific, for those who are eligible with praziquantel to be able to get rid of FGS. So community mobilization and education and counseling. All that we are saying, HIV counseling for mothers, promotion of behavior change and schistosomiasis treatments and prevention, including safe bathing practices for infants and children. So if it is the infant that we are talking about, then we are saying that there should be HIV counseling for mothers. As we are counseling them for HIV, we are also counseling them against FGS. At the same time, we are going to promote behavior change for schistosomiasis treatment. The hesitancies, sometimes when the drugs are even made available, because they don't know the benefits of the drugs they are going to take, they might refuse. So what we are saying is that there should be promotion of behavior change for schistosomiasis treatment and prevention, including safe bathing. You see, you live close to a river body, fresh water body, and you fetch the water right from the river and you are coming to bath the baby with the water. If that water is infested and contains the cercaria, then you are likely to infect your baby. So the women should understand the concept and the reason why, even if that is the only source of water in the community, then they need to boil before using. And then the mothers, being the adults, who by one way or the other come into contact with the water, should avail themselves for the mass drug administration to be able to kill the adult worms. the focus is elimination, and I think that is the target we all wish to arrive at. The HIV and then schistosomiasis, FGS, and HPV, as well as cervical cancer awareness, should be the hallmark in every community in Africa. As we saw in the map earlier, almost all countries in Africa are endemic, but the endemicity varies from one country to the other. And even in the country, the sub-districts or the districts or regions vary, the endemicity or the prevalence rate varies from one part of the country or the region to the other, but it is endemic everywhere. So what we are saying is that at any given opportunity, there should be HIV, schisto, FGS, HPV, cervical cancer awareness creation. The information should be readily available. Then we should also discuss with mothers, caregivers about the signs and symptoms of FGS. So first and foremost, we the health caregivers should be well versed with the symptoms or the pathological signs and symptoms to be able to impart same knowledge onto the mothers, and also refer them to the appropriate services that they need. Community-based outreach and demand generation for accessible uptake of the treatment and demand. I think I spoke much about this. So there should be access, logistics, including drugs available. Then there should also be inadequate provision of potable water, as well as sanitary conditions improved. So if wash activities are improved, wash structures are improved, and then we participate in mass drug administration, then there will be a safe environment for us all to live in. And we are moving to primary school children. Just elaborating. So with the primary school children, we have school health programs. We have school health programs, as well as school feeding programs, and then programs targeting non-enrolled children. These are great opportunities that we can leverage on to talk about FGS, to get these children, those who are eligible, treated. So as I think this applies to every country, because we have children in school and we have school feeding programs, those who have it running. And then we also have other programs targeting children out of school. So these are opportunities that anytime we have this opportunity, we should also think FGS and then create much more awareness. Then, as FGS interventions currently, we have age-appropriate comprehensive life skill educations, and then regular treatment with praziquantel as part of the worming programs in the countries according to the level of endemicity and then WHO's recommendation. In my country, Ghana, the endemicity has been subdivided into highly endemic, medium or moderate in endemicity, and then the mild. So mild will be those that have less than 10% prevalence rates. Those within 10 to 50, yes, less than 50%. So those less than 10%, they do it every mass drug administration every 3 years. Then those between 10 and less than 50 in the other year, mass drug administration. But those 50% or more, they do mass drug administration every year, once every year. But all this depends on availability of drugs. So what we are saying now is that the fight against FGS should be a national agenda, that there will be budgetary allocation to procure praziquantel and all that is needed within the health service delivery setting, so that to improve access to the service as well as the management. Then HIV interventions, extension of the deworming to non-enrolled siblings, and then safe water. I think all these things are services that are available. And we are saying that if that is the case, at any given opportunity, cervical cancer, there's so much noise, cervical cancer week, and then outreach programs are organized. What we are saying is that as you are talking about HPV, as we are talking about HIV, as we are talking about any other disease condition, think FGS as well. Then for community mobilization, education, and counseling, we're saying that education on schistosomiasis and other communicable and or tropical diseases in the area should be so much. You should create awareness on some of these, all these disease conditions, and age-appropriate comprehensive life skill education, including that of HIV, FGS, and then cervical cancer. Okay, so adolescents, 12 years to 19 years. In fact, what we have here is not different from what we have in the primary school children, but some of them become sexually active, and there should be so much. You started the education from the primary school, but the moment they are entering into adolescence, then much more effort should be made. So same school program or school health programs, we should be talking about FGS. Other programs targeting adolescents, both in and out of school, we should be talking about FGS. Then with HIV, we have other voluntary testing. So in fact, it's like, if you look at what is being done in other, just like we mentioned earlier, they run in silos. It shouldn't be. Therefore, or any other gynecological condition, number one should be FGS. Any opportunity, please make so much noise about FGS so that together we can drive it away from our continent. So I think the details you can read to see for yourself. Then women 20 years and above. We have the prenatal care services. We have the family planning services. We have HIV screening and prevention programs. We have sexual and reproductive health clinics, and many more. So at any given opportunity, in fact, right from the outpatient department, there should be so much that the PACE definition pasted on notice boards. Clinicians should be talking about FGS. All special clinics, as mentioned here, maternal and child health, HIV, STI, postnatal, antenatal, all the services that are already existing. We shouldn't forget about FGS. Any given opportunity, please talk about FGS. And if you have the opportunity to screen, do not focus on your STIs. For all you know, the symptoms that your client or your patient is presenting with, when she comes, you treat, goes and comes back again, might be due to FGS. So let us have the time and the health workers should have the time and take in-depth knowledge, in-depth history. That is the bottom line. And if there is the evidence that she had ever come into contact with freshwater body or recently come into contact with freshwater body, then it clicks. It should just remind you that you might be dealing with FGS. So all existing structures, all existing services, anytime you are attending to a woman, talk or think of FGS and then talk about it as well. And the moment it is found out that, yes, provisionally, she might be suffering from FGS, then they should go ahead and treat. So screen and treat is what we are vying for. Now, key considerations in terms of service delivery in low resource healthcare settings. So we are advocating for provision, or we are asking healthcare workers to provide clinical treatment, integrate with programs wherever possible in endemic areas. And this is not only the fight for the healthcare givers. It should be a national agenda. So that if, as I mentioned earlier, if there is a budgetary allocation for the procurement of all that is needed, the logistics for screening, posters, teaching materials, teaching aids, logistics for screening, and then the drug itself, data capturing, gadgets to be able to capture, and there is even a proper system for the data on FGS to be captured, stored for analysis and for use, then I think we should be aiming at not less than 65 to 90% the cure rates. So if you are able to organize yourself, service is readily available, praziquantel is available, you take your history, and then you find the woman suspected, or you suspect FGS, you go ahead and treat with praziquantel, 40 milligrams per kilogram body weight, and it's a start dose. And if we are able to do this, we are able to integrate the treatment, the screening and treatment of FGS into the existing structures that we have mentioned, and even many more, then we are aiming at not less than 65 to 90% cure rate. We are aiming at not less than 65 to 90. So 40%, 40 milligrams per kilogram body weight start cures about 65 to 90%. And it comes as a single dose. Treatment may be repeated if deemed necessary, and that will be the physician's own discretion. He will use his own discretion if there's the need for treatment to be repeated. There should be follow-up on symptomatic treatment of gross occlusive pathology as needed. Example, with ectopic pregnancies. We all know that one of the complications of FGS is ectopic pregnancy. It is possible. The physiology can be discussed. Then secondary infertility, sub-infertility, and many more. So if we have such cases, and then even if with all things equal, treatment is available, they've been screened and treated, there should be follow-up, structured follow-ups for these women, and that is where the physician or the prescriber will use his or her own discretion whether to repeat the treatment or not. Same for sub-fertility and then secondary infertility. Praziquantel is safe in pregnancy. Pregnant women can and should be treated. Note, incorrect diagnosis of female genital schistosomiasis lesions frequently leads to debilitating and irreversible operations such as ovarectomy, salpingotomy, and then hysterectomy. And I think I mentioned it earlier, that the consequences of FGS can be irreversible. The complications of FGS can be irreversible. So please, as health workers, let us take the mantle and create the awareness. Let us take the mantle and procure what is needed for FGS to be screened, or for our people, everybody, every woman that is eligible to be screened and then treated. But if it is tackled on dot basis, screen and treat on dot basis, as a country or as a continent, we should be able to make a headway. Then number 2, community-based interventions. We have to scale up and sustain public health approaches. Scale up and sustain public health approaches. Number 1, preventive chemotherapy. And this is done or termed mass drug administration or mass treatment of the entire community in endemic areas with a particular focus on school-going children. In some countries, yes, treatment is done based on the endemicity or the level of endemicity. But are we able to treat the entire community at a go? How many people are resisting? What is the data telling us? So if all these efforts, and we still have people, quite a chunk of community members refusing, then we'll be running in circles. So let us do much more engagement. Let us talk to our people for them to understand the consequences of FGS in their lives. And that it may not be immediate. So if they understand some of these things, there wouldn't be any refusals when it comes to MDAs. There should also be regular treatment with praziquantel from an early age to prevent schistosomiasis from progressing to genital damage and other related complications. As we all know, progression of FGS in women will lead to or can lead to FGS when the eggs are trapped in the female genital area. So regular treatment at an early age, and this will start with availability of the drugs, availability of praziquantel. So I'll mention it again and again. If it becomes a national agenda and there is provision for procurement of all that is needed for praziquantel to be procured, FGS to be screened and confirmed, then we are good to go. Number 3, we're going to address barriers to accessing treatment. And I think it keeps repeating itself. Ensure availability of praziquantel and its distribution within the health systems. Ensure availability of praziquantel and its distribution within health systems. It can also target treatment of females, women who have been treated with praziquantel at least once in their lifetime. Targeted treatment of females. So the information is that women who have been treated with praziquantel at least once in their lifetime have been found to be 50% less likely to develop FGS. The reason being that if you had ever been infected and then at a point in time you came across or you were fortunate to be treated with FGS, the adult worms had been killed. So there's the 50% less likelihood for you, less likely for you to develop FGS. So yes, one treatment once in a lifetime may not give you lifetime protection because schistosomiasis has the potential of reinfection. So being treated and then modification in your lifestyle modification, avoid coming into contact with freshwater bodies and other provision of wash activities or wash equipment, or yes, safe water, provision of toilets and so on and so forth, then we are likely to reduce the impact of FGS in our countries and for that matter, our continent. Key messages. Support integration of interventions for prevention and control of FGS through. So we are all being tasked, we are all being encouraged to support the integration of interventions for prevention and control of FGS. And we can do that, or we can achieve that by emphasizing presumptive treatment for schisto. Presumptive treatment for schisto. How do we achieve this? Detailed history taking. Detailed history taking. 1, the woman is showing symptoms of the pathological symptoms. Then during the history taking, she had ever come into contact with fresh water body or recently come into contact with water body. And the woman finds herself in an endemic area. You just provisional diagnosis schisto, and then you go ahead and treat. Number 2, increasing awareness for FGS among health workers and community is very important. And I'll bring my life story here, my practical story here. I started screening, or I was trained by the Female Cancer Foundation in the Netherlands and started screening for cervical cancer for more than 5 years when I had never heard anything about FGS. So 5 years on, when I was introduced and trained in FGS, on seeing the pathological lesions, I said, wow, we missed all these opportunities. And from that day, I set myself aside that I was going to help fight the FGS disease from my country and had been doing that till today. I am one of the sector or senior, how do I even say it, expert members in Ghana, subject matter experts in Ghana, FGS, SME in Ghana, and I had been making so much noise. I've been training as many as I can. I've been screening as many women as I can, and I've been making so much noise. And then Ghana today, we are making a headway. Not single-handedly, but we have a program that takes care of, neglected tropical diseases, of which FGS is one. And they are doing marvelously well. So awareness creation among health workers is also very important, because so many cases are going through our fingers, are slipping through our fingers because we lack knowledge. Number 3, targeted wash intervention, sanitation, water and sanitation interventions in endemic areas will stop or break the transmission. So inclusion in behavioral change interventions for health promotion, and then sexual reproductive health well-being is very important. All these put together and having it at the back of your mind, that at any given opportunity, you are talking about FGS, you are screening for FGS, and you are going to treat FG you are going to treat our women of FGS, will go a long way. So if not eliminate, will control the infection, the menace that is trying to engulf our continent. These are the references. You can look at them, pick each and every one of them. There had been some beautiful works on FGS, and you will never regret. So rich, talking about integration. These are our partners. I say thank you. God bless you.